Hello, I'm Pravachan Hegde. I'm the Director of Interventional Pulmonology and Advanced Thoracic Endoscopy at Community Health Systems with Community Health Partners in Fresno, California. Thank you, SAB, for giving me this opportunity to present on EUS, which is a very near and dear topic to me.
It's an absolute pleasure to have you on the podcast recording, Dr. Hegde. And you have a unique skill set in being able to sample a lot of challenging lung nodules and nodal stations. So maybe for our audience, you could go through why would a clinician want to combine both EBUS and EUS? Why are they complementary techniques?
Great question. So, adding, EUS and EBUS, they're not competitive techniques. They are complementary to each other. The reason I say that is, adding EUS to EBUS allows for more complete staging of the mediastinum, as depending on the lymph nodes we sample, and also greater evaluation of the lymph nodes and structures below the diaphragm. It allows for greater evaluation of lymph nodes compared to either of the techniques done alone. So with EBUS, you can sample lymph node station 1, station 2, 4, 7, 10, 11, and 12. The inferior mediastinal stations 8 and 9 are not accessible by EBUS. And the AP window stations, the true AP window stations, which is station 5 and 6, are not accessible by EBUS unless you go transvascular technique. In addition, sometimes a small station 4L can be challenging to access from EBUS as well. With EUS, you can sample stations 2, 3P, 4L, 5 and 6, which I will go over as to how we access 5 and 6 with and without traversing the blood vessels. And station 7, 8, 9, and structures below the diaphragm like the liver, celiac axis, and bilateral adrenal glands can be accessed by EUS. 4R can be challenging due to intervening trachea in small lymph nodes, which are less than 5 millimeter with EUS, but can be accessed in most cases when they are enlarged. So with the combination of this, you can get to most stations in the thorax as well as the structures below the diaphragm. A combination of these techniques have a higher negative predictive value compared to either of the tests done alone, which is about like 96% with the combination of technique versus 88% with EBUS alone. And in addition, some of these studies done on combination of EBUS EUS, for example, in the Wangbo study from Korea, what they noted was, interestingly, the lymph nodes that was missed by EBUS and picked up by EUS was not in inferior mediastinum, but it was in stations 4L, 5, 6, and 7 as well in Wallace's study on a combined EBUS EUS. This is because of better visualization of 4L and 7 from the esophagus as well, which is what they noted. There's also a 1 in 30 chance of inferior mediastinal station involvement, which is station 8 and 9, without involvement of the upper mediastinal station, particularly in lower lobe tumors. This becomes important in lobe-specific staging, especially in the current era of neoadjuvant therapy as well. And the meta-analysis looking at combined EBUS EUS studies, Korivar looked at this. He did a meta-analysis of 13 studies, and what they found was adding EUS to EBUS increased the sensitivity by 12%, and adding EBUS to EUS increased the sensitivity by 22%, and thereby making combination of this technique more sensitive and more accurate compared to either of the tests done alone. Therefore, if you look at the ERS, ESTS, and ESGE guidelines, they have adapted combination of EBUS, EUS over either of the tests alone in the guidelines for the mediastinal staging of lung cancer since 2014.
I think what's interesting about this technique is that we were previously trained to use mainly the bronchus or the trachea as our route of entry, but you obviously decided let's go through the esophagus and better access these lymph nodes. For the benefit of our audience, maybe let's go into your PowerPoint presentation and you can show us in real time what you're doing, and then we'll come back to some of the questions later. So let's move on to your slide set.
So basically, this is our preference card for staging. So all our staging procedures are with a combination of EBUS and EUS. With EBUS, we sample the station 2, 4R, and the hilar and station 11. With EUS, we go for station 4L, 7, 8, 9, and structures below the diaphragm. What you see here is, with mediastinoscopies, you can only sample upper paratracheal and lower paratracheal subcarinal lymph nodes. If you want to go for AP window, you have to go surgical staging with VATS or anterior mediastinotomy, also called Chamberlain procedure. But with the combination of EBUS and EUS, you can literally get to most stations and almost all stations in the thorax.
That's really important, as you said, because of the staging requirements. So maybe go through some of your more slides and give us some more information so that the viewers can see which stations you're targeting.
Yeah. So this is a diagram which basically shows you station 2R and 2L. So 2R above the innominate vein and 2L above the aortic arch. So here in this diagram, you can see aortic arch, and above it is 2L as seen from the esophagus here. So this is station 2R. You can see the innominate vein in blue arrow distal, to the station 2R here, as seen from esophagus. So station 3P, which is basically retrotracheal lymph nodes, we often sample this as well from the esophagus. This is a view of a station 3P seen from the esophagus, shown with the red arrow here. Station 4L and 5. So what divides station 4L and 5 is the aortopulmonary ligament. 5 is a AP window node. In most cases, we can access this via the esophagus without traversing the aorta. But sometimes, we also do aortic biopsy of these lymph nodes. We have a paper from many years ago in JTCVS where we published a case series of 36 patients with transaortic biopsy with no complications and about a 73% yield in that study. But later on, our group from Montreal, they went on to publish patients of 100 series of 100 patients where they did transvascular puncture of AP window lymph nodes, and with no complications, and the diagnostic yield was somewhere in the 80%. AP window lymph nodes can be biopsied with and without traversing the aorta. I'll show you a video later in the presentation. So this is a Mickey Mouse view of station 5. So as you can see, aortopulmonary ligament here, my arrow pointing separates 4L, which is above that, in between the PA and aorta, and this is station 5 after the aortopulmonary ligament here. I'll show you a video as to how we access this via the esophagus in a little bit as well. Station 6 is a para-aortic lymph node. So in this picture, you can see the aorta, left subclavian takeoff, and station 6 here, para-aortic lymph node can be seen in this picture. So station 7 as well, we prefer doing it through the esophagus. You know, the view was much better, and the visualization is much better. This is a station 7 subcarinal node in between the atrium seen with the red arrow, and then the pulmonary artery. When we do the EUS with the traditional convention EUS scope, the view is much better, higher resolution, and you have the two wheels and the elevator, and you can target the lymph nodes much better compared to the EBUS scope, which has a limited angle of view compared to a EUS scope, which is a larger scope with a wide angle view. So these are the inferior mediastinal stations to the right and left of the esophagus. In between the superior and inferior pulmonary vein is the station 8, R to the right and L to the left. And below the inferior pulmonary vein is station 9, which is basically inferior, inferior to the inferior pulmonary vein, and these are the pulmonary ligament lymph nodes, station 9. 8 and 9 are typically involved in lower lobe tumors. Here you can see station 8L with superior pulmonary veins seen in the view as well, distal to the lymph node. The picture of station 8R. And in this picture, you can see 9L and a shiny pleural line distal to the lymph node, close to the inferior pulmonary ligament. Now getting into the structures below the diaphragm. So this is a celiac axis node. So here you can see the aorta, and then a celiac axis lymph nodes are located immediately when the first branch of the artery takes off in the abdomen from the aorta, which is basically a celiac artery, and celiac plexus lymph nodes are located in that area. In the video going forward, I will be showing those lymph nodes and demonstrating how we access the lymph nodes. This is a gastrohepatic ligament lymph node. Here you can see a larger blue arrow pointing at the liver, a smaller blue arrow pointing at the hepatic artery, and this is a large gastrohepatic ligament lymph node which could be biopsied by transgastric puncture. This is a picture of a normal adrenal gland. So this is called a seagull sign, where the adrenal, the transverse axis of the adrenal gland is typically less than 8 millimeter. When it's enlarged more than 8 millimeter to a centimeter, we biopsy. Here in this picture, you can see a normal looking adrenal gland like a bird or a seagull. So to the right of the screen, you can see the kidney, and then spleen to the left, and adrenal glands typically is located above and anterior to the left kidney. This is a picture of adrenal gland that is involved with a metastasis, where the seagull is obliterated, and it looks much larger. We can go over the video now, or do you have any other questions for me, Dr. Pepper?
Okay, so Dr. Hegde, yeah, let's go to the video and maybe take us through how you survey all these lymph nodes.
So this is a video of a right upper lobe tumor with EUS staging only. So typically, when we do our staging, we start off with obviously a white light bronchoscopy, and then if you're doing a robotic procedure, we start off with biopsying the lung first. Then we go with EBUS next. So with EBUS, uh, we biopsy 4R or 2R is if it's enlarged, typically 4R for sure. So we start off with 4R, and then the contralateral hilum first before going on 4R. And we look at 11, 10 and the contralateral side, and then come back, look at 4R and 2R, and then ipsilateral hilum with 10 and 11. So once that is done, then we straight away go to EUS. With EUS, we introduce this scope all the way down to the stomach, and then survey the liver. So once we get to the abdomen, you turn your scope right first, and then survey the left lobe of the liver. Then we identify the spleen to the left, and then go a little bit distal here. And as you can see, there's a kidney, looks like a donut. So like I mentioned earlier, once the kidney is identified, we slowly pull the scope back up and look up and anterior, and adrenal gland is identified. Here, adrenal gland, this is a normal looking adrenal gland here, as you can see. And then this is a IVC. And the classic, this is so then we find the aorta, which should look like a large pipe to the left once you identify the IVC. And then, the celiac artery is the first branch which takes off, and then we identify the celiac plexus. If it's enlarged, we biopsy it. Then we come back and look at inferior mediastinum, station 9 and 8. Here, and then we pull back, find the aorta, thoracic descending aorta, which looks like a large pipe, as you saw, and then pull up and look at the arch here. Then between the arch, between the aorta and the PA, we identify the 4L, biopsy that. Then in the picture here, you can see station 7, which is between the left atrium and the PA. Right now, you're seeing station 8R, which is distal to the superior pulmonary vein, and now back to 7. So we identify this, 9, 8, 7, 4L, and this here, I want to demonstrate this. This is a station 4R. So you pull back, look to the right, identify the azygous vein, and then, in most instances, because of intervening trachea, you may not be able to see a small 4R, which is less than 5 millimeters. But then if it's enlarged, you are able to see 4R. Like I mentioned earlier, this is a staging of a right upper lobe lesion that is almost directly invading the 4R as well. With lesions that are close to the esophagus, we can even do esophageal lung biopsy as well. On the screen right now, you're seeing biopsy of the station 8R distal to the superior pulmonary vein.
So we can pause here, and then maybe you could just cover some important topics. So number one, it's a different scope. So are we able to access these with the regular EBUS scope? Obviously using the EUS, what did it take for you to start using the EUS?
Great question. So yeah, most interventional pulmonologists are very good at using the EBUS scopes and the mediastinal anatomy. So doing EUS through EBUS scope, which is basically USB. If you look at the data, there is not much difference between the yield when accessing um, certain stations accessible by EUS with USB or conventional EUS scope. The only difference I see is when in difficult locations, particularly in para-aortic station 6 or station 5, you may encounter difficulty in accessing those stations. And also in anema study, when they did left adrenal biopsy, in about 15% of the patients in that study, they could not oppose the scope to the gastric mucosa to get a good view of the left adrenal in that study, and they could only see the left adrenal in about 85% in that study. So I would say in difficult locations, and especially certain structures below the diaphragm, left adrenal, EUS scope, conventional EUS scope may perform better than EBUS scope in the esophagus. And also, right adrenal cannot be accessed in most patients with the EBUS scope in the esophagus through that route, because most of the time you have to go through transduodenal approach, and you need a conventional EUS scope for that. But in most mediastinal stations, there's no difference between the use of EBUS scope in the esophagus versus conventional GI EUS scope. However, I use both scopes, and the what I see is, with US conventional EUS scope, you have a larger field of view, and then you have two wheels, so you can approximate the ultrasound scope into the mucosa much better. And then EUS scope also has an elevator where you can direct the needle the way you want, and that makes it a little bit user friendly. But the studies which looked at using conventional EUS scope versus EBUS scope in the esophagus, the only thing that they found was, while using the EUS scope, conventional EUS scope, this procedure was a little bit longer compared to using the EBUS scope in the esophagus, because obviously it takes a while to take the scope out and then change the scopes and all that. So with EBUS scope, if you're staging, you do the EBUS and then go to EUS, and that saves some time as well. Does that answer your question, Dr. Pepper?
Oh, it does. And then in terms of antibiotics, are you routinely providing antibiotics for these patients? Any blood thinning recommendations? Anything different that you would do compared to a regular EBUS?
So there are some case reports of increased infection in cystic lesions and sarcoidosis. So if we are doing aspiration of a cyst, or if we are suspecting sarcoidosis, then we give them preoperative antibiotics prophylaxis. Otherwise, no routine antibiotic prophylaxis is recommended.
Gotcha. Let's go through another video, and then I'll come back to further questions.
So you saw the EUS with the conventional EUS scope in my previous slide. This is the view of EBUS scope in the esophagus. I just wanted to show you, the angle or the field of view is about 50 to 80, 70 degrees here, as you can see, and the conventional EUS scope gives you a much better view. So this is the aorta, and then celiac axis here, the branch taking off, and celiac axis lymph nodes are right here. We are in the abdomen here. So as you can see, aorta looks like a large pipe, and then you saw the celiac artery take off from there as well. Now we are back in the mediastinum. You can see left atrium, and this is station 7. And coming back up, this is the thoracic aorta, and you saw the arch in view as well. And then once we find the arch, we push the scope a little distal and then turn the scope to the right to find 4L between the aorta and the pulmonary artery. Now we are above the arch. This is the part of the arch with left subclavian takeoff here. You're looking at 2L there. So this is just a comparison between the two scopes and the view you get. So as like I said earlier, it's much the EUS conventional EUS scope gives you a much larger angle of view.
You definitely get more vision with the other one. I can see why you prefer it.
Exactly. So this is a slide where you can see the station 5 in between the aorta and pulmonary artery after the aorta pulmonary ligament. So this is a video of accessing station 5 from the esophagus. Here, this is the aorta here where I'm pointing out, and to the right of the screen is the pulmonary artery, station 5, you can see. And then closer to the scope is station 4L with a hilum, which is a normal looking 4L. And then aorta pulmonary ligament here separates 4L from 5, and we're going after the station 5. And using the elevator, we basically without traversing the aorta, we found a window in between the PA and aorta, and then we are accessing station 5 from this window here from the esophagus. This turned out to be a large cell neuroendocrine cancer in this particular patient who had an isolated station 5 lymph node, basically. The next one is the para-aortic station 6 here, as you can see. So this is a view from the front of station 6. You can see the esophagus here, right next to the trachea. We tried to access this from this window medial to the subclavian. I'll show you a video of how it's done in a little bit. This technique was actually described by my mentor, Moish Lieberman, a thoracic surgeon at the CHUM University of Montreal, where he published his first case series about 10, almost, I think 2012, where 12 patients with this new technique without traversing the aorta, accessing the station 6 lymph node medial to the subclavian and getting into that para-aortic window. The case series was of 12 patients. They got a diagnosis in all of them without any complications. So this is the window you use from the proximal esophagus. A needle is a window is found medial to the subclavian origin. Then using the wheels of the echo endoscope and the elevator, you pierce those lymph nodes to get to station 6. Contrary to the belief that station 6 can only be accessed transvascular technique, it's not true. It can be accessed without traversing the aorta as well. In this picture, you can see the aorta here, left subclavian, and then from the blue dot here, this is your window you access to station 6. On the picture, you can also see the PA here as well. So this is a video of how you access station 6 from the proximal esophagus. So as you can see, the needle, the elevator is used to direct the needle into the station 6 lymph node in between the subclavian artery to the left, medial to its origin, and then a window is found and biopsied. This is a transvascular technique. So basically, aorta here, and then through the aorta, you go in and access station 6 lymph node in the para-aortic window. So, the published literature, we published our series of 36 patients back in 2016, I think. About 73% diagnostic yield going through the aorta and PA, and no complication. Then further, the same group in our group in Montreal published a case series of 100 patients in JTCVS a few years ago, and um, no complications seen. And it is certainly very doable. This next video is a video of left adrenal. So we not only biopsy the left adrenal through EUS, we also place fiducial markers for our radiation oncology colleagues for SBRT in isolated adrenal mets. Here in this video, you can see the enlarged left adrenal. So obviously the bird has become a fat bird here because of the metastasis. I say that because usually the adrenal looks like a seagull, a small bird, and when there is metastasis, it's it's enlarged and looks bigger than normal, obviously. So here you can see once the on-site cytology is confirmed for metastasis, we are placing fiducials transgastric way using the conventional EUS scope into the adrenal. You can see the shiny fiducial here in between, confirming the placement of fiducial in the adrenal gland for planned SBRT. This case, the on-site was positive, patient got fiducial, and one and done.
Impressive. So what kind of skill set does one need to have, and what kind of training did you go through? Because obviously not everyone is facile with EUS. What training would you recommend folks have? How many cases should they do before you would say, you know what, you're proficient and should be doing this safely?
Great. The advanced bronchoscopists, interventional pulmonologists, they do a plenty of mediastinal staging, and so they, after having done a lot of hundreds of EBUSs who have knowledge of mediastinal anatomy, the learning curve is short. The classic approach that Jensen in Europe, what he described in his paper was, basically when you just start doing them to learn the 6 landmarks for EUS in the order of, he described this for uh, learning the EUS initially, first based on a simulator based training, which might shorten the learning curve, and then it can ensure some basic competence before unsupervised performance. The landmarks that he described was in the sequential order here, or liver, that we saw our video how we follow the same thing too. So we first liver, then identifying the aorta, and then left adrenal, and station 7, 4L, and 4R, and then try finding them in order. And once you with the IP and advanced bronchoscopy's knowledge of mediastinal anatomy, the learning curve is short. And I can usually after about 25 to 50 cases, people get more familiar. And in the GI literature, they say after about 140 cases, you become very proficient in it. But obviously, like with any procedure, it's the learning curve. And to me, the learning curve was similar to learning the EBUS. When I finished my general pulmonary and went for advanced interventional training in Montreal, when I started learning EUS, personally, the first 50 cases, I was trying to uh, find, assess the mediastinal anatomy. But after 50 cases, you become more familiar, and then after about, once you cross that 100 cases, you will be more proficient in doing EUSs. Obviously, you have to um, take care of certain things that you don't do. Like, for example, if there is resistance, you don't push. And, um, if you're insufflating, it's better to use CO2 rather than air to mitigate the complications. Those are some of the things. But for to answer your question, most people who have been doing EBUSs, after about 25 to 50 cases, they become pretty comfortable. And once you reach that 100 cases, you become very proficient.
Gotcha. And then here you have a case that you recently shared on LinkedIn or with the thread. So maybe talk us through this interesting case that you had.
Yeah. So this on the video, on the screen here is um, left, close to supraclavicular lymph node, station 1 on the left. So this is a young patient with a vulvar cancer, actually. And then when they did a preoperative scan, they saw this lymph node in that area. Initially, the patient was sent to IR, and because of the intervening vessels and from access perspective, they said no, and our oncologist sent the patient to us. So we accessed this in the proximal esophagus, in the groove between the left subclavian and the left carotid here in this window here. It was a challenging uh, uh, lymph node to access. So here in this video, I'll walk you through. So you see the arch of aorta here, and then you see the left subclavian takeoff, and then we became proximal to the esophagus, trying to get in the window there. And obviously, when you're in this area, the one thing that you have to be careful is to make sure there is no aberrant vertebral artery takeoff from the early takeoff of vertebral artery from the left subclavian. Uh, Here you can see the lymph node. I'm trying to see if there is any vessels close to the EUS window here. So this left carotid kept coming in the way, and then I had to, the thing with the esophagus is it's mobile, right? So, and the other thing that I always find interesting between the conventional EUS scope and the EUS B is the you can move the esophagus much better with the conventional EUS scope, because of the stability, and it's a larger scope. So, you're able to get that window by moving the esophagus a little bit more than what you can achieve with EBUS scope in the esophagus. Here, we moved the esophagus a little to a window where I could see this lymph node and biopsy it here. Finally found this window here. So this is the window that was used and accessed, and turns out it was a squamous cell cancer, which is similar to morphology to her vulvar cancer, and HPV positive. Very, very rare presentation of a vulvar cancer to go into the left supraclavicular area.
That's pretty impressive. Wow. Where can folks read up more on this literature? I know that in the ERS monograph, you have an article or a chapter there entitled Minimally Invasive Endosonographic Techniques Combining EBUS and EUS. I think you share that with Dr. Lieberman, your mentor. What other resources can folks use to get better acquainted?
So, we have a paper in operative techniques in thoracic surgery a couple years ago, where we talk about the techniques and technical tricks of combined EBUS and EUS. I think at the end of the talk, I have I displayed that. So that is one thing I could, we could use as a, resource for a beginner who wants to. There's a lot of uh, lymph node pictures there. If you go to the original article in the supplement, that could be used as a source to start doing, and and identifying the mediastinal anatomy from the esophagus. Most of the times, it's just identifying the mediastinal anatomy. Once you get proficient with that, needling, we all, as endoscopists, we all know how to needle a lymph node, so that's not a problem, as long as we are opposing the scope to the mucosa well, and not throwing the needle in the transmural area. So, simple things. The same with the same technique we use with EBUS, right? So, oppose the scope well to the mucosas, continuous suction. As we know, air is an enemy of ultrasound. You don't want any air in between. And also, opposition is important for you not to throw the needle in the intramural area, and then go transmural um, into the target. So the lot of people have said that paper has been very helpful for them, adapting the EUS with USB scope as well, for the beginners when they started doing. So that's a paper I would point out to.
Gotcha.
And
And then you said you're using mainly needles. I would assume that most of these cases you would not be doing cryoprobe. We in the bronchoscopy field have become pretty enamored with the cryoprobe. I'm assuming you're not using cryoprobe routinely.
Cryoprobe through the esophagus, absolutely not. It could be dangerous, and we never do cryobiopsy through the esophagus. Cryobiopsy, always we go transbronchial. But anecdotally, I'll tell you that when I have a case of lymphoma, we do cryobiopsies from the transbronchial side, and we do with a conventional EUS scope. We use the EUS FNB needle, 22 gauge, and I have found no difference in the yield when both structures can be accessed via EBUS and EUS. When I've done cryo through the EBUS and then gone and done a EUS FNB, or using a Francine needle, 22G, I have found no difference in the yield, and both have picked up a diagnosis of lymphoma or sarcoid in that patient population.
Gotcha. So, Dr. Hegde, as we move towards the end of this recording, what parting advice or instruction would you give our listeners who are interested in performing this technique, that would want to improve their patient care but make sure that they do it safely?
Yeah, first thing is getting familiar with the anatomy, and those sequential landmarks, the 6 landmarks starting off. Identify the liver, aorta, celiac axis, left adrenal gland, station 7, 4L and 4R. Once a simulator based training may help as well. And people, if they're really interested, visiting places which do them routinely and observing the workflow would be helpful. And we do have observers that come and learn, both locally and nationally. People have visited and then they've gone back and adapted it, and uh, that'll help as well. And like I said, for most IPs who have done hundreds of EBUSs, and have the knowledge of anatomy, learning curve is short, and knowing, identifying the anatomy is the most important thing. And first I would say start doing it with the EBUS scope in the esophagus, get familiar, and then once you get more familiar, then you can go with the conventional EUS scope after. The main challenge I see for someone who's starting would be, from a turf perspective, right? So your GI colleagues may oppose it. I would talk to them and explain that you're mainly doing this for thoracic malignancy staging. You're not touching the esophageal cancer or anything else. And once you talk to them, they most of them understand. And you can also learn from advanced GI when they are accessing mediastinum through EUS for their esophageal cancer staging, for example. You can still go and learn the anatomy from them if you have a good rapport with them. And I would also have the thoracic surgery surgeons on board as well, in case if you have a complication, which rarely happens, less than 1% complication. And if you ever have a perforation that needs a stent or whatnot, having a good rapport with the thoracic and GI colleagues may help in those situations. But I can tell you, I've been doing this for 11 years as an attending. I've not had a single complication from EUS, and I mean, it's been described. And some of the complications can be mediastinitis, some edema, perforation, pneumomediastinum, or mediastinal hematoma, which is less than 1% in the large literature that's been described. One thing, if I would screen before you attempt EUS, just from history, is history of dysphagia or history of esophageal dilatation. If there is stricture, try to avoid. You don't. And then also history of varices. If they have had a varix, try to avoid it. But most, sometimes coincidentally you do diagnose varices when you go through the esophagus with an ultrasound probe as well. And if you see that, try avoiding puncturing through it, and don't do it via the EUS. Some of the other things technically is, like obviously I just mentioned it a little while ago. Make sure the probe is approximated well into the mucosa, and if there is resistance, do not push. And we talked about cystic lesions and sarcoidosis. Try giving antibiotic prophylaxis in that population only based on the case series. And if and when you use insufflation, use CO2. The risk of pneumomediastinum, if there is a microperforation, is low with CO2 and it's better absorbed rather than insufflating with air. Those are some of the things that I would keep in mind for a beginner who is starting to do this.
That's really insightful comments, and really appreciate you taking the time to speak with our audience, Dr. Hegde. For our audience, we based this discussion on his publication in ERS, Interventional Pulmonology. The chapter is entitled Minimally Invasive Endosonographic Techniques, Combined EBUS and EUS, and I would definitely encourage you to read that article and reach out to Dr. Hegde if you have any other questions. Thank you, sir. Appreciate you.
Thank you. So here, this is the paper on the screen that I was mentioning earlier, where we have the technique and technical tricks with some pictures in the supplement. This paper could help a beginner. And thank you so much, Dr. Pepper, for having me. It's been a privilege and an honor. I have my email and phone number shared on the screen for anyone who wants to get in touch, coming visiting, or any help I could offer. And I would like to thank my mentor Moish Limmerman for all the training that I got with comprehensive thoracic endoscopy and EUSs. And also I want to shout out my previous fellow, Brandon Kraft, who hopefully will be a future IP fellow. He helped me put together some of these videos and pictures as well. And again, thank you SAB for having me.